Hi class, in this lecture we will review drug therapy for nausea and vomiting. The objectives are listed on the slide and they're also listed in your Blackboard module. There are several vocabulary terms that you should review. You should be able to find definitions in your textbook.
So a couple definitions. Nausea is just the sensation of feeling like you need to vomit, and then vomiting is actually the forceful evacuation of stomach contents kind of in a retrograde fashion. We also talk about retching. I don't specifically have the definition here, but retching is kind of that physiological response that is impacting the muscles of your diaphragm and your GI tract, and is going to lead to actual vomiting or cause the forceful evacuation of stomach contents. So nausea and vomiting is regulated by a pretty complex reflex. It's brought on by the activation of the vomiting center, which is a nucleus of neurons in the brain. And there are a variety of different neurotransmitters that influence nausea and vomiting. So we'll talk in detail about those. There's a couple different types. Now, I just have some of the more common types listed on the slide. Chemotherapy-induced nausea and vomiting, post-op nausea and vomiting, nausea and vomiting related to pregnancy. But patients can experience nausea and vomiting for any variety of reasons. These are just some of the ones that we see specifically in the inpatient setting and obviously in the outpatient setting as well. So this is a diagram that's from your book. You can read a lot more about this in your book. I'm just going to kind of go over some of the highlights and kind of this is really more kind of a pathophysiologic review for you guys in reference to how nausea and vomiting are triggered. So there are several sources feeding signals for nausea and vomiting to the vomiting center in the brain. Some are direct, some are indirect. So let me start with the direct triggers. So looking at this picture, kind of look at the right side of the picture. Starting in the center, you've got that little ball in the center. That's the vomiting center. And that vomiting center can be directly signaled by signals from the cerebral cortex. So for example, fear or even anticipation of fear, memories of fear can actually trigger the vomiting center and lead to nausea and vomiting in some patients. Sensory inputs, signals like taste, sight, smell, memory, emotion, these are sensory inputs. These can lead to nausea and vomiting. So just seeing or smelling something repulsive can instantly cause patients to feel nauseated or even in some cases vomit. Other direct signals, signals from the vestibular apparatus of the inner ear. And so the inner ear senses motion and body position. And so signals that are indicating that motion or body position kind of is out of alignment can lead to a sense of nausea and vomiting. Usually when we think of this, we think of motion sickness or car sickness or even seasickness, which is really just motion. These are all really just motion sickness. And there are neurotransmitters involved in that kind of complex process. So the inner ear receives these signals, and neurotransmitters like histamine and acetylcholine are responsible for mediating those messages to the to the vomiting center, which will induce vomiting and nausea and potentially vomiting in some patients. There are also indirect signals. So looking at this picture over on the left side, we have some of those indirect signals. So the chemotrigger zone, which is part of the brain, will receive signals from the stomach or the small intestine. Usually it's due to toxins that are binding at receptors in the small intestines or the stomach. And those result in a message from the chemotrigger zone that influences the vomiting center and induces nausea and vomiting. So ingesting a toxin can be a source of the indirect stimulation of nausea and vomiting. Other things like blood-borne emetics. So in the blood, there are sensors for toxins that are located in the blood that can lead to activation of the chemo trigger zone and ultimately activation of the vomiting center. So all of these different signals that the vomiting center receives, these will signal the stomach, the diaphragm, and the abdominal muscles, resulting in a coordinated response to expel gastric contents. And that's where patients begin to feel nauseous, they begin to retch, and then ultimately they can experience vomiting. And so from this diagram, you guys can see there are a bunch of different receptor types that are involved in this process, and thus the neurotransmitters that signal or bind to these receptor sites are targets for drug therapy. So some of the medications that can be used to prevent nausea and vomiting: serotonin receptor antagonists, substance P neurokinin antagonists, dopamine antagonists, cannabinoids, other things like glucocorticoids or benzodiazepines. These are drugs that can be used to treat nausea and vomiting or reduce the occurrence of nausea and vomiting. So let's start with the serotonin antagonists first. These are highly effective drugs. These really are first-line drugs for treatment of nausea and vomiting, especially serious nausea and vomiting like that associated with chemotherapy or anesthesia or even pregnancy. So the prototype is ondansetron, brand name is Zofran. These drugs block serotonin type 3 in the chemo trigger zone. So they're blocking the receptor, and thus the chemo trigger zone is not activating the vomiting center. So that's going to decrease the symptoms of nausea and vomiting. Therapeutic uses, so they're used to suppress nausea and vomiting secondary to chemo, radiation, anesthesia, so both chemo-induced and post-op nausea and vomiting, as well as pregnancy, and even in some cases viral gastritis. So I said that sometimes the nausea and vomiting could be related to toxins, such as those that could be associated with either bacterial or viral gastritis. The viral gastritis in some patients, we will actually use the serotonin antagonist to decrease the nausea and vomiting, and usually in certain populations like kids, where you're really concerned that nausea and vomiting could lead to dehydration and electrolyte imbalances. Individual variation, these drugs are QT drugs, so that means they have the potential to prolong the QT syndrome. So patients with congenital long QT syndrome, these drugs should be avoided in those patients. For patients who are on other QT prolonging drugs, there would be serious consideration as to whether we would really use these drugs as well, because that additive effect could be life-threatening. Patients with structural issues with the heart, like heart failure, Brady dysrhythmias, we would be concerned, or even electrolyte imbalances. And really, in the end of the day, all of these side effects go back to the fact that these drugs prolong the QT interval. Side effects: headache, diarrhea, and dizziness, most common. There is that risk for prolonged QT interval, so you definitely need to be familiar with that. Nursing implications: you want to identify those high-risk patients and make sure they're not getting the drug if they shouldn't. The next class of drugs are the dopamine antagonists. Our prototype is prochlorperazine. These drugs are actually used pretty commonly. They're really at this point second-line agents, but they are used in conjunction with other agents such as the serotonin antagonists. These drugs block dopamine and histamine receptors, mostly dopamine receptors, but they also do have some histamine receptor blocking activity, which does influence nausea and vomiting. They are used for a variety of types of nausea and vomiting, so vertigo or motion sickness, so nausea and vomiting associated with that. They could also be used for post-op nausea and vomiting or chemotherapy-induced nausea and vomiting. But these drugs, just so you know, we're going to talk about these drugs again. They have CNS uses specifically for patients who have schizophrenia. Right now, we're just talking about them kind of in the context of prevention of nausea and vomiting. Adverse effects that can be seen with these drugs: Because they can activate a variety of receptor types, dopamine receptors, or I'm sorry, block a variety of receptor types like dopamine receptors, histamine receptors. These drugs can also block alpha 1 adrenergic receptors. They have a variety of adverse effects associated with them. Sedation, orthostatic hypotension, sedation because they block histamine receptors, orthostatic hypotension because they block alpha 1 adrenergic receptors, extrapyramidal symptoms, which they fall into 4 categories, but some of which are acute dystonia or tardive dyskinesia. For now, at this point in the course, what I want you to know is that they can cause extrapyramidal symptoms. Don't really worry what those are. We're going to talk about antipsychotics um, towards the middle to the end of the course, and we're going to talk extensively at that time about extrapyramidal symptoms. I will put a couple links on your Blackboard module so that you can look at kind of like a real patient and what it looks like to have an extrapyramidal symptom. But we're going to talk a lot more in detail about these when we talk about the antipsychotics. They can have anticholinergic effects, and that's also because they can block cholinergic receptors, and they can also lead to extravasation. So promethazine is a dopamine antagonist. It's very structurally similar to prochlorperazine. It's not our prototype, but I want you to know that that drug in particular can lead to serious extravasation. In terms of individual variation, these drugs are contraindicated. Well, not these drugs. Promethazine in particular is contraindicated in kids less than 2, and that's because it can cause life-threatening respiratory depression. Also, in general, we do try to be cautious in using these medications in the elderly population, mostly because they block all of these different types of receptors and they can have um, exaggerated effects in elderly population. This is a picture just to show you what it looks like. This is a real picture of a patient who received Phenergan in a small vessel of the hand and ultimately developed an extravasation which led to gangrene of the digits. So this patient probably is going to have an amputation. So this is bad. I mean, this is a young woman whose hands were perfectly fine, received Phenergan, or promethazine is the generic name, through a small vessel of the hand and had that extravasation, which it's hideous. Here's another picture. This patient actually got promethazine in an arterial line in his wrist, supposed to be given into an intravenous line, but it was given into an arterial line. And you can see the results of accidental intraarterial administration. So that's a big no-no. This drug should never be given intraarterially. So obviously in this case it was an accident. But we also don't give this drug into small veins because the risk of extravasation and complications from extravasation is higher. So this particular patient, again, is going to have amputation of his thumb and finger. So some safety concerns, I've already mentioned these, but let me reiterate them. Specifically with promethazine, respiratory depression in kids under 2. This drug should never be used in kids under 2. It's contraindicated. There's no scenario I can think of where this medication would be so necessary that we would take a chance and give it in a patient under 2. It just wouldn't happen. Extravasation, again, specifically with promethazine. Now again, promethazine is not the prototype. Prochlorperazine is the prototype. But as you guys know, sometimes there's something so important about a drug that's not the prototype that we have to bring it up. And for promethazine, these safety concerns are very important for you to be familiar with. So some nursing implications in general with the dopamine antagonist. You want to monitor and definitely educate your patient to look for signs and symptoms of extrapyramidal symptoms or side effects, low blood pressure, sedation. Anticholinergic adverse effects could be seen with these medications, so you want to educate patients to look out for those and potentially give them ways to minimize those anticholinergic effects. Additionally, for promethazine in particular, we try to avoid the IV route if possible, and we never give sub-Q or intraarterially. If it does have to be given intravenously, like I said, we try to avoid this. But if the medication does need to be given intravenously, a couple things. First of all, it must be diluted. Most likely, when you give this, it's going to be in an inpatient setting, and you're going to go to the Pyxis machine or the automated dispensing cabinet to remove that medication. The form that's stocked in that cabinet by pharmacy is a concentrated form. It's got to be diluted. So it's 50 milligrams per mil is the way it's commercially available. You've got to dilute that down to 25 milligrams per mil or even less when you administer this. What we used to recommend when I worked at Hopkins was you take that dose and you shoot it into a 50 ml mini bag and you run that mini bag over some period of time. Sometimes that's not possible, but that's usually the ideal way to give it. Additionally, it can't be run fast. It shouldn't be run any faster than 25 milligrams per minute. So the drug needs to be, if it is going to be given IV push, it needs to be pushed slowly over a couple minutes. Finally, this drug should only be given through a large bore vein and with a freely flowing line. You don't want to give this into small veins because the consequences of extravasation would be more concerning. The next class are the substance P norokinin antagonists. The prototype is aprepitant or Amend. These drugs are also very effective, but they're rarely used on their own because they have a unique mechanism of action. Typically, they're used in conjunction with other drugs like the serotonin antagonists. They're used for post-op nausea and vomiting. They're also used for delayed and acute chemo-induced nausea and vomiting. So these are the most common uses. These drugs are pretty expensive, so they tend to be reserved for patients that have pretty severe nausea and vomiting. These drugs have a prolonged duration of action, and so that's why they're good for both acute nausea and vomiting as well as delayed chemo-induced nausea and vomiting. For the most part, they're pretty well tolerated. Some adverse effects that have been reported, fatigue, dizziness, diarrhea, and hiccups, for the most part, they're tolerable, and the drugs themselves are rarely discontinued because of side effects. The issue with these drugs is that there are a lot of drug interactions. So I'm not going to ask you to memorize all of those, but what I do want you to know that if you have a patient that's on one of these medications, you need to be assessing for drug interactions for your specific patient. And then, of course, educating patients for the potential for drug-drug interactions. So if they're taking this medication in the outpatient setting and they're prescribed something new, they need to make sure that their prescriber knows that they're already on aprepitant and that there's a potential for drug interactions that needs to be evaluated. All right, and let's talk about the last drug class, the cannabinoids. The prototype is dronabinol or Marinol. The mechanism for how these drugs work is not completely known, but it's thought that they're probably activating receptors near the vomiting center that are specific for cannabinoids. Just so you guys know, this drug is related to marijuana. Dronabinol is the active ingredient, THC, which is delta 9 tetrahydrocannabinol. That's the active ingredient in marijuana. That's the ingredient in marijuana that produces the euphoric effects. So it's the principal psychoactive ingredient in marijuana. And so because of that, these drugs are scheduled. There is the abuse potential. However, in real life, even though there's that theoretical concern that these drugs could be abused, the onset when taken via the oral route is pretty slow for this particular drug. And so it doesn't produce the same type of high as marijuana would produce. And so because of that, there's not really a street drug interest for dronabinol. But nevertheless, it is a controlled substance. So you have to follow all of the procedures that are in place for Schedule III controlled substances. Some potential therapeutic uses, obviously, chemo-induced nausea and vomiting really is a second-line drug, and that's just owing to its risk for abuse. It's also used as an appetite stimulant. It's approved for use in patients with AIDS-induced anorexia. And then in terms of adverse effects, we worry about sedation, tachycardia, confusion, potentially euphoria, although that's not something that's seen all that frequently. And then, like I said, there is the potential for abuse, even though kind of in the real world we really haven't seen this drug abused to any great extent. All right, and the last drugs I want to talk about are the drugs for motion sickness. And really, motion sickness is just, can result in nausea and vomiting. So that's why that's kind of like the chief complaints when somebody's got motion sickness. The chief issue is that they're nauseous or they're vomiting. So the drug that's going to serve as our prototype, we actually have two drugs that we're going to talk about. The first class are the anticholinergics, and the prototype is scopolamine. The brand name is Transderm Scope. This is a transdermal patch that's applied every 3 days. It needs to be applied before the patient experiences motion sickness. It won't be effective if it's it won't be as effective if it's used after motion sickness is already um, onset. It's less effective. So this drug works by blocking histamine, acetylcholine, and serotonin activity, mostly acetylcholine activity, but it does have some binding at histamine and serotonin receptors as well. Therapeutic use, obviously, for motion sickness. And like I said, really, we use this as a preventative measure. We would initiate this medication when somebody is going to engage in an activity that might cause motion sickness, like going on a cruise or driving in a car or going on out on a boat for the day, things like that. Some of the adverse effects that we worry about: drowsiness, hypotension, dry eyes, dry mouth, blurred vision, constipation, urinary retention. Every one of those should look familiar to you. And that's because these are your anticholinergic side effects. The things that we see most commonly in terms of anticholinergic side effects are drowsiness, dry mouth, and blurred vision, but any of those things we have listed there could potentially occur. Nursing implications: obviously you want to educate your patients on ways that they can avoid anticholinergic side effects. So if dry mouth occurs, they can suck on sugarless candy, and so they're still able to have benefit from the medication from a therapeutic perspective, but you can give them some methods to minimize some of those adverse effects that typically occur. Sedation is another thing that patients should be warned about. And this is prescription only. A lot of patients think this is over the counter, but this is a prescription only drug. And this is what it looks like. So transdermal scope, it's a small patch. You place it behind the ear. It only comes in one strength, 1.5 milligrams, and even on the packaging, which you see on the left there, there's a diagram showing the patient how to administer it, or showing the nurse who would be administering it, kind of how that needs to be administered. The last drug I'm going to talk about is dimenhydramate, or Dramamine. This drug is an antihistamine. It blocks histamine activity. Therapeutic use is, again, for motion sickness, can cause sedation, can cause some anticholinergic side effects. The main issue with Dramamine, though, is that it causes sedation, that it is just too much for people to handle. So a lot of people really think hard about whether they're going to take Dramamine or not to resolve their motion sickness, because usually it means they're going to be in bed sleeping, because it does cause some pretty profound sedation. Nursing implications: obviously methods to avoid anticholinergic effects, as well as the risk that this drug's going to cause some serious sedation. And this one's over the counter, so patients have a little bit easier access to this medication.
Thank you for listening. If you have questions about this content, please post it to the discussion board. Thank you.